if you've had blood drawn in the last month, there's still a tender spot in the crook of your elbow, and that spot is where a disagreement about your care can begin. One tube. It goes downstairs, and part of what comes back is a number for how well your kidneys are working. Your cardiologist reads that number, the pharmacist checking your blood thinner reads the same number off the same page, and the two of them can arrive at different doses, both defensible without either one being careless or rushed. When two doctors disagree about an older patient, the easy explanation is that they trained in different specialties or have different temperaments. Underneath that sits something plainer. The information they were each handed didn't match, even when it came from the same tube. Before I get into how that happens, one thing. If you're the person in your family who ends up in the room asking the questions, subscribing puts this kind of material in front of you ahead of time, where a hospital number actually comes from, and who chose the method behind it, because none of it helps much the week after someone has already handed you the number. So, that kidney figure was never measured. In ordinary care, nobody measures kidney function directly. They estimate it from a creatinine level using a formula, and there are three in common use. Feed identical blood into all three, and in old age they pull apart. Among people at age 85, the share with reduced kidney function comes out at 90% by the oldest formula, 55% by the second, and 68% by the third. Same people, same blood. That gap doesn't stay in a laboratory. FDA labeling for the newer blood thinners. The direct oral anticoagulants was built on the oldest of the three formulas. Most hospital labs print one of the others on the screen. So, the pharmacist may be recalculating by hand with one method while the number in front of the physician came from another. Measured against each other on real patients, the two approaches agreed at 0.47 on a scale where 1 is perfect agreement and 0 is what you get from chance. What that means where you're standing. When someone tells you your dose was changed because your kidney number came down, the accurate version is that an estimate came down. You can ask which formula produced it. The pharmacist will know. That's a number with 3 accepted answers. The scores are looser, because a score has no formula behind it at all, just a person with a scale. Frailty scoring decides real things now, whether you're offered an operation, whether intensive care takes you, how far the plan is willing to go. In one Canadian intensive care unit, an intensivist and a geriatric medicine resident separately scored 508 newly admitted adults. Their agreement came out at 0.32, fair, on a generous reading. Their own reading of that figure is that the two of them weren't scoring the same underlying thing. The geriatric side leans on how a person was functioning before and what the family reports. The intensive care side leans on physiology and how the body is responding in front of them. In Swedish emergency departments, the overall reliability was considerably better, and yet 3 professionals assessing the same patient still landed 2 points or more apart in a third of cases. 2 points on a frailty scale is roughly the distance between offering your mother the surgery and deciding she wouldn't survive it. Nobody in that conversation is being dishonest with you. A score at least gets written down. The advice that changes plans most often never does. And this next piece is standard practice in every hospital in the country while being almost unheard of outside them. When your doctor tells you they ran it past cardiology, there's a fair chance cardiology never laid eyes on you. A specialist gets stopped in a corridor, hears a short description of a patient, and gives an answer. No note, no name attached, no record that it happened. At one university-affiliated safety net hospital, researchers took 50 of those informal requests and arranged for 47 of the same patients to be formally evaluated the same day by a different hospitalist. The information passed along in the corridor was inaccurate or incomplete in 51% of cases. After a real evaluation, the management advice differed for 60% of the patients. Where the initial description had been wrong or incomplete, the advice differed 92% of the time. That sentence, "We checked with cardiology, they're comfortable," lands like the strongest reassurance in the conversation. What sits underneath it is a summary of you, even from memory, answered by someone who never met you. The number and the score at least come out as a single value. Words are worse. Imaging reports don't say yes or no. They hedge, using a small stock of standard phrases, and the doctor receiving the report has to translate the phrase back into a probability. At one large academic center, 59 radiologists and 100 primary care physicians, all averaging more than 15 years in practice, were asked to convert those phrases into a percentage likelihood of cancer. The two groups diverged on every single phrase tested. The widest gap of all was on consistent with, the phrase that sounds the most settled. Pathology carries the same seam. On a 10-point certainty scale, one hedging phrase covered a range of 4 to 5 among the pathologists writing it, and 1 to 8 among the clinicians reading it. Your two doctors can be looking at the identical sentence, disagreeing about how worried to be, neither of them quoting a different fact at the other. And the cutoff that turns a lab value into a diagnosis in the first place is often set building by building. Take D-dimer, the clot test. Of 20 laboratories checked in Ireland, not here, so treat it as a demonstration of how this works rather than an American count. Only 3 had moved to a cutoff adjusted for age, though a fixed cutoff flags a great many people over 50 who turn out to have no clot at all. The same argument is live for cardiac troponin. Sex-specific reference limits have been recommended since 2018, age-specific ones aren't endorsed, and the values differ significantly by age regardless. All of that assumes the argument is about your treatment. The next finding reframes the rest, because it concerns something the room never says out loud. In a single-day screening across multiple hospitals, 757 admitted patients aged 65 and over were given a brief cognitive test. 347 of them, 46%, showed cognitive dysfunction. The nurses caring for those patients recognized it in 42% of cases, the physicians, 48%. In 42% of cases, neither the nurse nor the doctor had noticed it at all. Which means 2 clinicians can be at odds over your treatment while quietly holding different views about whether you're able to weigh it, and neither has necessarily said that part aloud, including to each other. That question, whether a person can decide for herself, is also a legal one, and it changes at the state line. 39 American jurisdictions have a statute naming who may determine that a patient lacks decision-making capacity. 12 have nothing written down at all. Of the 39, 29 require exactly 1 clinician's determination. 6 require 2. Maryland and South Carolina go 1 or 2 depending on the circumstances. New York generally starts with 1 and adds a confirming opinion for certain patients. And in several states, that clinician doesn't have to be a physician. A nurse practitioner, a physician assistant, or a psychologist can make the call. In most of the country, one person's judgment moves your decisions to somebody else. In a handful, someone else has to agree with them first. Whoever that one person is, they may not be the same one next week. Attendings on hospital wards typically hold the service in blocks of 1 to 2 weeks and hand the entire list to a team that has never met any of the patients, commonly on a Sunday or a Monday. Nothing about you changes that morning. Across 95 2-1A2 patients in a Canadian analysis, exposure to one of those changeovers was associated with about 2/10 of a day of additional stay and a lower likelihood of being discharged on the changeover day itself. Across 10 Veterans Affairs hospitals and more than 230,000 admissions, end-of-rotation transitions were associated with higher in-hospital mortality, an absolute increase of 1.5 to 1 percentage points where the handoff involved interns. That last figure needs its edges left on. It's an association from a large study that wasn't randomized, and the authors noted the effect may concentrate among patients already having a long or complicated course. It is not evidence that the change of doctor harmed anyone. Still, if the plan changed on a Monday and your father's condition didn't, the calendar is a fair thing to ask about. So where does all this actually live, if you want to look at it? Federal rules for hospitals require the record to contain the results of every consultative evaluation and the findings of other clinical staff involved in the care, and require each entry to be legible, complete, dated, and authenticated by the named person who ordered, provided, or evaluated the service. The disagreement between your specialists isn't a rumor in a hallway. It exists in writing, with names on it. And since the 5th of April 2021, a federal rule has required that this be released to you immediately. Progress notes, consult notes, imaging narratives, laboratory and pathology results, with withholding permitted only under narrow exceptions like a specific safety or privacy risk. You can read a note the day it's signed. There's a cost to that nobody planned for. Asked about it at one academic center, 84% of hospital clinicians said they now leave specific information out of their notes because patients can read them, and about 4 in 10 said patients found the notes more confusing than helpful. That's 46 respondents at a single hospital, so take it as a direction rather than a measurement. But a rule written so you could finally see your doctor's reasoning has, by their own account, moved some of that reasoning out of the notes entirely, and that strikes me as a poor trade for the person lying in the bed. Which leaves the last question, what if what's written there is wrong? This is the only piece in the whole of this that you can act on by yourself, and it tends not to come up until a family is already deep in a dispute. Under the federal privacy rule, you can request an amendment to your record. They have 60 days to act, with one 30-day extension if they notify you in writing. They're allowed to refuse. Their refusal has to come in writing, and it isn't the end of the process. You may submit a statement of disagreement, your own written account of what you say is inaccurate and why. The organization must attach or link that statement to the disputed material, along with their denial and any rebuttal they choose to write. I'm explaining paperwork and process here, not your treatment. What's right for your body is a conversation between you and the people actually caring for you. But if a diagnosis you dispute has been following you from one admission to the next, that's the mechanism that makes your objection follow it. Once the statement is filed, it goes out with the disputed part of that record every time the record is disclosed.